We don't address problems of will that way, in the same way. It's not an issue. Instead, we talk about how he's willing against the therapy. So when he says, "You're making me anxious," I say, so I wonder what feelings that triggers here toward me.
I see.
Now, it'd be very different if you have a borderline patient. You're trying to destroy my marriage. See, that would be a clear projection, right? Where we would have the patient really misperceives you in a way where there's absolutely a temporary loss of reality testing. And then you could have to say, but am I destroying your marriage, or are your behaviors at home destroying the marriage? Right? We would have to do something with a borderline patient to reestablish causality and reestablish reality testing. Here, this gentleman is in isolation of affect, right? He's intellectualizing, rationalizing, detaching, and so on. His anxiety is constantly in the striated muscles. There's no problem with reality testing. No problem with reality testing at all. And that's why, in a sense, Samantha wears the transference. Well, all right, so insofar as I represent this demanding father, what feelings are coming up here toward me? She agrees to wear the transference, to wear an image of a person.
So is it safe to say, in isolation of affect, we shouldn't be much concerned about clearing the transference?
Well, again, it's more a matter, you see, it's a fragile patient. You're trying to destroy my marriage. The patient is projecting something onto you, and they've lost reality testing. You have to deactivate the projection so the patient has a realistic view of you. Otherwise, they'll have a misalliance with the projection. In isolation of affect, the patient is not projecting a part of himself onto you. This patient is projecting an image of his father onto you. That's different. He's projecting an image of his father. That's what we call transference. So when there's transference and isolation of affect, we need, in effect, wear that image. So we'll say, so what feelings are coming up here toward me? Yeah. So, and you might help the patient a little bit if they're a little bit puzzled, but So you're saying I remind you of your father. So I wonder what feelings are coming up here toward me. So it's not that you have to clear up the transference, you actually are welcoming the transference. It's not a problem. So insofar as I represent this transference figure from your past, what feelings are coming up toward me? You don't have to clear it up.
That's
you actually wear it. You actually wear it. Whereas when you have a projection in a fragile patient, we have to clear up the projection so the patient has a realistic behavior toward you, or a realistic perception of you.
It goes back to differentiate transference from projection.
Exactly. And many people don't understand that, right? Projection, I project, so I could project Salman hates me, right? So I'd be projecting my hate, or Salman was wanting me to answer these questions, right? I'd be projecting my will on the Salman. That'd be very different if I said, well, you just seem like a really critical, domineering person. You just remind me of my father. And at that point, you realize that I'm not projecting something of myself onto you. I'm actually projecting an image of my father onto you, and that's the transference. And then if I can have this image that Salman is my father, I could be angry at Salman, and that's a way that I'm actually avoiding the anger toward my actual father, because it's actually displacement. So you say, so instead we just say, so insofar as I represent your father, you have what feelings are coming toward me, and the patient is kind of like, they didn't expect that. And then through the unlocking, then since resistance drops, then the memory comes to mind of the parent.
That makes a lot of sense.
Good. Well, it's a fantastic question. Thank you. It's a common one, and it's very important to be able to differentiate projection of a part of oneself versus projection of an image onto you, which is a transference.
Thanks.
Other questions people have, reflections.
Hi, Jon. I have a question.
Yes, Fatma.
If the patient said that I'm angry and has sighed and say I feel a strength in my arms, but I don't feel anything in my torso, no any hotness, anything. is a time to go through portrayal, and it happened very soon in just second session.
Okay, so you asked what feelings are coming toward me, and the patient suddenly says, I have this
Not suddenly after some pressure intervention after 30 minutes in second session.
After 30 seconds?
30 minutes in second session, yeah.
Okay, so after 30 minutes, the patient says he has this impulse, but he doesn't feel anything else in his chest or anything.
Yes.
And does he sound detached or look detached?
No, no.
He really sounds and looks angry.
I'm not sure. Yeah, not very angry, but yes, angry. Not very angry.
Yeah, well, of course, without seeing the video, right, I could only speculate, right? So, because ordinarily what I'd be looking for is, does he sound angry? Does he look angry? Do we see an impulse? Have we heard
I can see the impulse. Yeah, I can see the impulse. Yeah.
Impulse. Okay, if you got impulse, I think I'd be tempted to say, so in thoughts, words, and ideas, how do you picture the rage going out onto me in your imagination? What does that look like?
Okay, okay. I was thinking.
And then we would see. Now, sometimes we have enough of our eyes and the portrayal just happens. Sometimes you go to the portrayal and then defenses come up and then you realize, okay, got some defense work to do.
Okay. Thank you.
Because no matter how sure we are, we might discover, oh, it wasn't enough of our eyes. It can happen. But if you really had those impulses, yeah, I'd say, and so if all that rage came out onto me in your imagination, in thoughts, words, and ideas, how do you picture that in your mind? Yeah, what does that look like in your imagination?
And no matter, he doesn't feel anything in his body.
Pardon
me? It's not a matter that he doesn't feel anything in his body.
I think if you've really got the impulse, I'd be tempted to go with it. But again, you see, right, when we do it, remember, it's not whether it's a right or wrong answer. I think this is where I can help you. Whenever you intervene, you're testing a hypothesis, right? So without seeing the video, just hearing it really has the impulse. I would say, I think there's enough of a rise. And I say, so in your thoughts, words, and ideas, in your imagination, how do you picture how that rage would go out onto me? In your imagination, what does that look like? And then we'll see, can he actually have a portrayal? Did we have enough mobilization? And we'll find out during the portrayal if there was enough mobilization, or we'll find out that there's some resistances we needed to address, and then we realize, oh, okay, there were some resistances here I have to address. So remember, it's not that we never know with certainty. We think, okay, this looks right. I think this is good. So I'm going to test this hypothesis. And you test the hypothesis. And if it turns out right, great. If it turns out it wasn't enough of a rise, great, because now we're learning what further resistances you need to work with. So I think one of the important things to remember is that in doing psychotherapy, it's not a matter this is right or this is wrong. We actually don't know in advance, right? We're scientists. So when you intervene, you form a hypothesis. And then your intervention is how you're testing the hypothesis. Every intervention is an experiment. And so, okay, I'm going to intervene based on my hypothesis. And sometimes our hypothesis is confirmed, sometimes it's not. Either way, it's great news. Either you got your portrayal or you learned, oh, these are the resistances that are in the way. I got great unconscious supervision. We're ready to go.
Exactly, yeah. Thank you.
I think this is very important because like when you see videos, it's easy to think, oh, the supervisor or teacher or presenter always knows exactly where to go. No, it's not true. The supervisor or teacher presenter is very good at formulating hypotheses and testing them. And then sometimes they work, sometimes they don't, but then they're able to see, oh, I need to do more of this, or I need to do more of that. So the really great supervisor is not someone who knows what to do. They're just simply someone who's good at learning from the patient all along and listening to the patient's unconscious supervision. Because see, in the end, I'm not really your supervisor. I'm actually here to help you listen to the true supervisor. So like you're asking, is that the right thing to do portrayal? Without seeing the video, I can't know. Even if I saw the video, I couldn't know for sure. I'd say, I don't know, when you do it, let's see what supervision your patient gives us, and we'll find out from the true supervisor whether that was right, or we'll find out from the true supervisor what more work needs to be done. So it's very important that it's not about right or wrong. Don't get yourself hooked up with that. It's like you test a hypothesis, the supervisor in the room, your patient, will always let you know where to go. I'm just here to help you listen to the true supervisor over time.
Thank you. Thank you for your answer.
Thank you. That was a fantastic question. Thank you.
Could I piggyback on that a little?
Oh, please.
So earlier you talked about social taboos, and before you came, they were talking about you have to make ISTP what's natural. But could I frame two different mindsets? So the old pattern is social taboos where everybody collectively covers up anxiety and keeps up appearances and pretenses. That's what we're socially conditioned. And
Absolutely.
This new pattern is trying to call out those defenses, the masks that everybody hides behind, and then slowly try to redirect to mobilize for feelings and emotions. You've labeled that as asking for unconscious supervision. Could that also be framed as process approach, where you're trying to trust underlying processes from the unconscious and helping them appear through experimentation, discovery, exploration, testing?
Oh, yes, yes, right. Because it's really a form of iterative sequential experimentation.
Mm-hmm.
Right, we're conducting a series of experiments, and it's iterative, and every patient response is refining our understanding. So our knowledge is always changing in response to the unconscious and conscious feedback from the patient.
So it's very dynamic.
Well, you could think of it as a relational epistemology.
Mm-hmm.
It's not like I know an object, but the person is actually informing and changing my thinking and understanding.
Then the knowledge base is in the person's unconscious, but also in the relational dynamic, instead of some culturally imposed right or wrong.
Because the patient will be giving us feedback through conscious feedback, unconscious defenses, unconscious anxiety, unconscious feelings, unconscious defenses, unconscious transference, right? So we're getting multiple modes of unconscious feedback that's supervising us so that we can find out what's the unconscious logic driving the conscious illogic.
The conscious illogic. One of the things I sometimes do is when I notice there's a dissonance between what people say consciously and what their behavior is, which is a dissonance. So then I sometimes try to point out that the behavior that's not matching their conscious claim.
Yeah, exactly. Yeah, because you say you want this, right? You say you want a closer relationship with your husband, but then you had this affair. So it sounds like you're actually at war with your own desire.
Mm-hmm.
Yeah, that would be a very classic kind of ICDB presentation. That'd be a way of talking about conflict, very, very similar to what you'll read about, for instance, in Patricia Coughlin's writings. Yeah, she very frequently is using that kind of analogy and that way of pointing out there's a difference between what someone says and what they do. Absolutely. Yeah. Because remember, what the patient says, what the patient is conscious of, is the result of defenses. Defenses remove everything that's uncomfortable, right? Defenses remove everything that's uncomfortable. Whatever is left is what we're conscious of. So the patient can only give a conscious report based on what defenses exclude. So if we listen only to manifest content, we're only hearing what the defenses let get through. Everything else is on the other side of that filter. So we're having to listen to what the patient says, but then we're also having to listen to see, okay, what's What are the defenses warding off? First of all, what are the defenses, and what are those defenses warding off? What's the information that's being excluded from the patient's report? Like a patient says, yeah, I want a good relationship with my husband, and you're having to remind her, which she's temporarily forgotten, that she had an affair. You're actually having to remind her what she temporarily forgot. Oh, right. Yeah, it's true. You do want a better relationship with your husband, and at the same time, you had this affair, right, which would actually destroy the very relationship you want. So you seem to be at war with yourself. Yeah. Do you notice that too? In that sense, you're reminding the patient what's on the other side of the filter. Just like here in Samantha's case, the patient might say, I just can't do it. Now, for him, that seems like a fact. I can't do it. For him, that's a fact. It's manifest content. We would look at it in terms of a defense, and we would also look at it as a way of relating to the therapist. So as a defense, we'd say, oh, and could that thought be underestimating your true potential? I never thought about that. Yeah, could that thought be unfair to you? Samantha's also where I represent a father who is probably, who thinks he can't do it. So Samantha is hearing unconscious dimensions of that statement. For the patient, he thinks, I can't do it. That's all it means. Samantha says, oh, could that thought be hurting you like your father hurt you? Could that thought be underestimating your potential like teachers underestimate your potential? Could that thought be underestimating your potential like your father did? So would it make sense for us to look underneath that thought so we can discover your true potential, right? It gives you a sense, right? For him, it seems like a fact, and we're having to help him see, actually, it's not a fact. It's a defense. It's a way you're talking to yourself the way teachers did. It's a way you're relating to yourself as your father did. You're probably even afraid that I would think this about you, the transference. So at that point, you see this patient, when he says, I can't do it, he views it as a fact. He doesn't realize it's a defense. He doesn't realize that that defense has a price, that it's actually causing his depression. All that's happening outside his awareness. I want to come back to a question that Charlotte asked in the chat. She says, since this is an online therapy, as a therapist, you can't see the impulse in the hands of a client. So how do you handle this barrier in an online therapy? I'll just wait. I'll just wait until I see an impulse, or if I don't see one and the patient seems activated, I'll say, so is there an impulse that comes up with that anger? Maybe they say, yeah. And how do you experience that impulse? Right. And then that will allow me to assess, first of all, is an impulse conscious? Are they experiencing an impulse? They might say no, or might say yes. And I say, and how do you experience that impulse? How do you experience that physically in your body? And that oftentimes is a way for me to assess online whether there's an impulse in the lap that I don't see. So Yuval is thanking us, wishing us happy holidays and everything. So I want to thank all of you for such a lovely fall, such lovely cases we've had a chance to study here together as a group. And thank you again, Samantha, for this lovely case. It's lovely to see your progress here sailing along. And I'll look forward to seeing you in the coming year, where we have all the dates set for the spring, and look forward to seeing more of you present cases so we can keep learning from these patients who are always trying to supervise us. So thank you, Yuval, for coordinating all of this for us. And thanks to all of you for creating such a supportive environment for our presenters.
Thank you, John.
We should have a special hand for Samantha here.
Well, thank you everyone, and thank you, John, so much. I'm so grateful. Thank you.
Oh, thank you. And I'll look forward to seeing all of you in the new year. Take care, everyone.
Bye-bye.
Okay.
Happy
Bye.
holidays.
Thanks, you. Bye.
Bye-bye.
Bye-bye.
Bye-bye.